To say that selective thyroid cancer dissection is a selective neck dissection, so it's a 2A, 3, 4, 5B, and this is a patient who actually had a thyroid lymph node biopsy elsewhere, came back as metastatic PTC, and then came to CMC. And so we've used the incision in such a way that we extend to incise or excise the scar, raise flaps as usual, and we do our neck dissections for thyroid cancer through the same thyroid incision, which we use and extend that more laterally. And to go to the lateral neck, we use the lateral approach, and what nodes are medial to the IJV is dissected off and sent separately, which includes level 2A. And so we go up on the IJV and as shown here, and then that's level 2A, and this is the head end of the patient, that's the foot end of the patient. And so these nodes are sent separately. I heard in the morning that the en bloc 3, 4, 5 is sent all lateral to the IJV, but what is medial to the IJV would possibly be sent as separate. But I don't think it's really a matter. So that's the bulk of nodal disease, that's lower down, level 4, and a lot of discussion was there about the Chi leak. This is a right side MRD or a functional neck dissection. This is a trick I do, that is to cut the clavicular head of the sternomastoid to get a little bit more range. You put a gauze piece through, lift it up, and then you have access to the nodal mass or the nodal basin, and that's where you can see the phrenic nerve. That's actually the accessory nerve, the phrenic nerve. That's the end to show the boundaries of the dissection. But this was just to show that this is the area which we are operating in. And so that's the transverse cervical there, and you could save that too. And we just use a ligature vessel sealing device to take off the nodes from level 3, 4, and then move on to 5B. So you can see the twitch there which happened in the sternocleidomastoid and the trapezius, and then you know that's where your accessory nerve is, and there's a dissection which shows there. And we don't go above the accessory nerve if there are no nodes. If you stay below the accessory nerve for that part of the dissection. And all of that then gets taken off, leaving behind the fascia on the prevertebral muscles, which will then keep the phrenic nerve within it, and you don't damage it. So that's the boundaries. That's the accessory there, that's it. Then the and we do that is the brachiocephalic there actually, and the IJV. So we've done a whole clearance, and on the right side we can discuss about techniques to prevent Chi leak. And this is now coming back to the thyroid, and this is the upper pole. That's the muscle was in the transverse incision of the muscle, and that's the seam for the external branch of superior laryngeal nerve into that space. There, that's the nerve up there, and you see the vessel, the superior pole close or lower down. And then you do a snip and the strip of the capsule of the thyroid, and then you can see your parathyroids coming up. And you stay close and high up on the thyroid. And I think most people would talk about nerves when you talk about thyroidectomy, but I think you talk about parathyroids when you talk about thyroidectomy. And that's the most important part. And this is another thing I saw in the morning video on the Big Four, the handling of with the bipolar. Through our audit, we found that our temporary hypoparathyroidism was higher, so we went to using on to clips on the parathyroid and drop it down, and that will help us, help us reduce our rate of hypoparathyroidism. And as I said, that's the tubercle, and this is the nerve which is below it. So when you rotate the tubercle, you'll see the nerve. So say, let the nerve come looking for you, don't go looking for the nerve. And so that you can see was the inferior para now coming with a clip and dropping it down off the thyroid which is sitting there. So you can see a lot of dissections happening on the para. And that's actually a protuberance of the thyroid gland. So it's a remnant of thyroid and the parathyroid sitting on it. So hence we be careful that you don't leave behind thyroid. And actually thyroidectomy is an embryological operation, not an anatomical operation. You remove all the remnants of the thyroid. And then that comes to the central neck, which is the part of the dissection, and that's the nerve being dropped down. And so that enters into the central neck, and you can actually take off the, that's the last bit of the thyroid coming. And I sort of don't be dogmatic on using vessel sealing devices, but when you're close to the nerve, use a tie, there's no problem in it. And then you're sure that you have, so you can see that you've got a clear plane there, and the well vascularized inferior para and the superior there. The superior actually sits between two branches of the nerve. That's the anterior branch and that's the posterior branch of the parathyroid sitting in between.
મારી બેટરી પતી ગઈ છે પણ હજી 30 મિનિટ બતાવે. બેટરી છે.
That's the other lobe. Okay, I think it moves quickly onto the central neck dissection. So it's
અવાજ આવે છે.
Yeah, so that's the central neck dissection, and you can see the whole thing is about the nerve. You dissect out the nerve right down, keep the lymph nodes up. You can seal it, you could use bipolar, you could use some vessel sealing device or even ties to take out the central neck. And mind you, there would be nodes even below the rectophalangeal nerve in the paratracheal groove, and you need to be aware of it and take that out too. So at the end of it, the whole nerve is skeletonized, and that's the esophagus just below, and all of this bulky lymphatic tissue along with the lymph nodes is taken out completely. So I use a combination of a bipolar set on low settings along with a vessel sealing device to do this. And I can tell you, doing a thyroidectomy, especially the neck dissection with a vessel sealing device, has brought down our operating time by 1.5 hours. So earlier days we used to take a long time to do a big dissection, but this has really improved our timing. And for us that's a big thing because operating time is a premium. And that's the thymus. That's the end of the horn of the thymus, and we don't go into the thymus. If you're doing a metastatic MTC or you're doing a thyroidectomy for MTC, that also comes off. So that's the nerve below, and that's thymus, and all of that comes off. So that's the vascularity to the parathyroid being dropped down. That's the vascularity to the parathyroid. So taking off the parathyroid off the central neck is a challenge. If you're not clear, if you're not comfortable, auto-transplanting the inferior parathyroid in a central neck dissection makes more sense than to leave behind a devascularized parathyroid. So that's the whole thing, and final bit coming off so both the nerves being really skeletonized. So that's the nerve, yeah. The inferior para with its blood supply. That's the superior para in between the nerves. A little bit congested. I think I did use a knife onto it. It's a knife test, a 15 blade onto it to make an incision and let out a capsular hematoma, keeps the parathyroid well vascularized. And that's the other side, and that's the final specimen. And to show that actually even in a setting, okay, by the way, this is Dr. Kaustav had asked me to speak on the fact that, to speak on neck dissections for mediastinum in well-differentiated thyroid cancer. There are a few settings you would use. I'll go through that. If you've got small sub-centimetric nodes in the mediastinum, don't bother to go after them. You've got bulky nodal disease, especially below the brachiocephalic vein, open the chest. If you've got bulky nodes above the brachiocephalic vein, you could try to take it out through the neck. above the brachiocephalic vein, because it comes up in the extension, and if it's mobile, you will just rotate with the extension in the neck, you just get the nodes out. But otherwise, it is good to prepare for a sternotomy. This is a partial sternotomy, and that much nodal disease was taken out from below. This is, you can see the big fellow there. And so, these two approaches, a full sternotomy and a partial sternotomy. In this patient, coming back to the patient, I demonstrated her PTH was 20.8 post-op. She did go on to calcium supplements and she went home well. Thank you.